Good afternoon, everyone, and welcome. So, just as a bit of housekeeping before we start, it's 1 o'clock. We'll just give it a couple of minutes for people to join. If I could ask if people would like to just say hello in the chat, if you just use the chat function to say hi, where you're from. We've got Sarah Gallagher and Callum are both online as well. They're both in the sort of, you see them listed as presenters here, and they keep a track of the chat. They will try and interact with you while the meeting is going on. You'll notice that you've been automatically muted and had videos disabled. This is so we can try and coordinate it. So send your questions in through the chat as well. And we will also get feedback at the end. And if it's okay with everyone, we will be recording this meeting. And so the recording will be available afterwards, and the transcript will be available afterwards. And on that note, I think I need to ask Callum if we can set the recording going now.
It's automatic, James.
Oh, thank you, Sarah. So while people are putting their chats in, by way of introduction, so it's a pleasure to be here. I'm James Galloway. I'm a rheumatologist and epidemiologist based down in London. I have the enormous privilege of working with the National Audit as their methodologist lead. And I'm going to be talking to you today about some of the changes in the audit, and I'll go through what I'm going to talk about in a minute. I'm aware that the audit carries a substantial burden on clinical practice. The changes, I think, the communications that have come through, I think inevitably take time to filter through to all departments, and I know there's a lot of stakeholders. So we've got a series of these webinars. I hope you'll look out for the future webinars, and also please communicate with us, because that's how we know what's going on the shop floor. So what I'm going to cover today over lunch today, I want to give you a few pointers on what has changed in the audit. I'm not going to go through that in depth because I know that there's been previous webinars talking about the change of the audit, but I will touch on the key headline about some of the diagnostic changes. I want to share with you just about some of the dashboards, because we've done a lot of work behind the scenes to try and improve the functionality of the audit platform, and that's going to continue to improve. And I think you'll continue to see changes over the next months and years to try and make sure that the audit dashboard is useful for you to try and drive local quality improvement work. And so linked to that, I'm going to share with you and just show how you access your data, or for that matter, national data if you were interested. I'm going to get you to try and think about some ideas for QI, and I want to actually just flag up the opportunity to apply for best practice awards. The deadline is quite soon, so just I'll come back to the end, but the BSR Best Practice Awards 2024, the link is it's super easy to find if you just rheumatology.org.uk/BPA, and it is open for applications. I suspect I might be able to convince Sarah or Callum just to put the link in the chat as well if you are thinking. And I mention this partly because obviously it's great for people to apply for this. It's a great way of sort of showcasing innovation around the country. We're sort of hoping, of course, as well that some of these may be linked to the national audit, of course, but obviously there's lots of other examples of best practice unrelated to the audit. So what's changed? Well, probably there's three, if I had to say three big things that have changed in the audit. One is about what diagnoses we include. Another is about what the metric that we are capturing, that we are going to report to HQIP as being the key metric in the audit. And that has evolved in light of changing NICE guidelines and the NICE quality statements that have changed, and also the national data opt-out. So I'm going to start by going through these things in just a little bit more. First thing is about diagnoses to include. If you log onto the audit platform, you will have already seen, and if you've attended our webinars that we've sort of been building to this over the last, well, probably 12 months now, we started getting comms out that HQIP a year ago asked us to change the remit of the audit to broaden it beyond early inflammatory arthritis. The key question here is that at the moment, to understand waiting times for the breadth of rheumatic diseases, it's very difficult to access good quality data that says how long do you wait to be diagnosed with any of the rheumatic diseases outside inflammatory arthritis. And there was concern from a number of units, and I think very valid concern, that the impact of the national audit was this perverse incentive to prioritise inflammatory arthritis over and above, for example, lupus or ANCA vasculitis, which obviously are diseases which are in many ways diseases you'd want to see quicker than someone with an early inflammatory arthritis because of the consequences in terms of renal damage or other organ damage. However, there's a couple of things I think that's really important to understand about how the audit has changed. What the audit is doing in its remit, the primary role of the audit remains the assessment of how we care for people who are newly diagnosed with inflammatory arthritis. So a first presentation with rheumatoid or PSA, in undifferentiated inflammatory arthritis, how we diagnose them, get them onto treatment, and whether they get a good disease response in terms of a DAS response at 3 months. That is still the essential component of the audit. And when we look at the audit standards, and I'll come to that in a sec, you will see that they still remain very much focused on this particular part of the pathway. So from a starting point, if you think, crumbs, they're putting all these other diagnoses in, how are they going to judge us on these other diagnoses? The headline is, we're not judging people. There is not a HQIP benchmark for what you have to do for all of these other diseases. All we're actually trying to do is just get data out there to say, well, how long do people wait? And when you look at your region, you will then be able to compare waiting times for diseases like GCA or lupus for your region compared to other regions. And that's going to be the starting point, because at the moment it is so difficult to try and access this data nationally and say how much variation is there in care. And I think at our heart, we all appreciate that the purpose of the audit is trying to reduce that variation. We know some patients in some parts of the country get much better access to care than in other parts, in other regions. And by doing the audit, we can highlight that, and then we can help services who have longer waiting times leverage that information to say, we need more resource, we need to look at services. And so the purpose of the audit, I know some people feel it's like it's a stick, and we're beat a stick to say, can you do more work? It is not intended like that. The goal is to get data out there that's good quality, that allows people to look at services and say, can we do the best for patients across the country, not just in a tertiary centre. There's another point here, though, that I do need to mention, and one is, if you look in depth at the diagnosis, take, for example, ANCA vasculitis. If you said, when do I put data in for these diagnoses, what am I putting in? Am I putting in a BVAS? So the first thing says the data collection for any of the non-inflammatory diagnosis is very brief. We're asking for data referral, data diagnosis, and if a patient consents, if they're happy to give you their email address, they can have an email address put in, and they'll be sent the patient report and outcomes. And those questionnaires will be sent out to them automatically once their email address is in the system, and the patient can opt out at any time. There's a couple of things that are slightly tricky for an ANCA vasculitis diagnosis. What is the data referral? What is the diagnosis? And you have to make a clinical judgment, because that, if it's an inpatient, the date of referral would be the day you've received the referral on the inpatient referral system, and the date of diagnosis would be the date you got to see them, which might be the same day. And so there may well be quite a lot of the ANCA vasculitis I know that have an inpatient diagnosis. You may not enter them into the audit for some months later. And the audit, you can enter people retrospectively, because you whilst you get them in the inpatient, it might not be till their first outpatient appointment that you click up that they need to go into the audit, that you pick them up and get them into the system. But the timing should be based on when they were referred to our specialty and when they were diagnosed. So, for example, if someone has a referral letter where it's a vague, non-specific referral letter that was sent in June, and they get seen after 12 weeks and they get the diagnosis 12 weeks later, that is the referral to diagnosis delay. And don't think when you're doing this, oh crumbs, this is going to reflect badly on me, because remember, everyone in the country is doing this. There is not a standard against which you're being judged, but it's going to enable you to look and say, how are you doing compared to other parts of the country? The purpose being, if you are taking longer, then you can look at your service and say, what can we do differently? I'll come back to that. The second thing is about what the metrics are. So the NICE quality standard updated, and it updated during our last audit cycle. Now, we didn't change the metrics that we were measuring against for the most recent. You'll see the annual report will come out in the coming months, and we stuck to the metrics we used, so they were consistent throughout the first 5 years of the audit cycle. But for the next 5 years, notwithstanding whatever changes may happen in years to come, or global warming or whatever, for the next 5 years, the key metric will change from the time, because what we were saying is that the old quality statement 2, which was time from referral to diagnosis, was our key metric. But that actually has been removed in the NICE quality standard 33. So the new metric that is going to be the benchmark metric is going to be time from referral to treatment. So this is going to be the metric which would be looked at just for those with inflammatory arthritis, just for those who we're sort of from the original audit cohort that we're collecting, not just the baseline time to diagnosis, but also the additional information, that extended data set that we capture. That is now the metric which we are judging people for, quality statement performance, and that's what we would report as a headline to HQIP and the CQC and onward. And so that's the key metric, how long it takes someone from the time they're referred to when they start treatment. And I haven't mentioned it explicitly in this audit webinar, but I've mentioned it in previous ones, and I hope most of you have now realised that we have removed the requirement to enter patients with suspected inflammatory arthritis who don't ultimately get diagnosed with one of the inflammatory diagnoses. Now that we know from historic data collection, we know that made up about between sort of 60 and 70% of the data entry. And by removing that, that's massively reducing the data collection burden, but we're replacing it with the data collection information on the other disease areas. But it also is part of the reason why the time from referral to treatment now becomes the key metric, because obviously now we don't have time from referral to assessment, which was what the old metric used to be. We were assessing that not just on those ultimately diagnosed with rheumatoid, but also on those with suspected rheumatoid who may have been ultimately diagnosed with fibromyalgia or osteoarthritis. And so that information going forward will no longer continue to be reported as one of the benchmark metrics. I will come to questions in the chat if there are later, but I'm now going to touch on the next big issue, which was the data opt-out. I hope most of you have heard of the National Data Opt-out. This is not a rheumatology specific thing. This is a national service that allows patients to express their choices about what their confidential patient information is used for. And that includes not just research, which you can opt out of, but also planning and audit. So patients can opt out of their data being used for the purposes of audit. And I think we have, over the last few years, worked under a position where the national audit programs, of which we are one, were exempted from the data opt-out. So we had a confidential advisory group approval to undertake the project without consent. So that's the CAG 251 approval. And then we also had a national data opt-out exemption. Almost all of the national audit programs have had the opt-out exemption removed. We are appealing, and so this is still, we may see things change, but at the moment, as it currently stands, we as an audit, like all of the other national audit programs, are not exempt. I would really encourage, if you are involved in managing the audit at your hospital, I'd really encourage you to make sure you've read the National Data Opt-out guidance, because this is all prepared centrally, and so rather than me articulate it in a slightly different manner, it's important you read it for yourself. And the link is at the bottom of the website here. It's on the NHS digital website. They've got really good guidance on what this means, both for a patient, but also for a healthcare provider engaged in data collection, and how organisations can comply with it. There is, in short, a very simple mechanism whereby all the trusts have a facility to upload a set of NHS numbers, and then you get back a list of those which have not opted out, and that enables you to work out who has opted out from the central spine. Now, this is definitely going to create challenges in the logistics of delivering the national audit, and if ever there was a really strong argument for saying the trust's audit department should be involved in this audit, this is one of them, because the trust's audit department are doing this already for the other HQIP national audits, of which there are over 50 now running of national audits that are part of the mandated NHS contract. So the audit departments are familiar with what is required for this, and they are the ones that you need to work with. So how do we locally ensure that we're compliant with the national opt-out? One thing I would say, just with regards to national opt-out, is also to remember, because people worry about what happens if I put someone in and then I found out they've opted out. Well, you can of course remove people. So if you find out someone has opted out, and again it's on the FAQs, we can remove people. So and the data aren't being processed at the moment. If you enter the data at the moment into the audit website, the data goes in, but it's not being sent anywhere. It's not being shared with anyone. That happens once a year where we do the data extract for annual reporting. Before then, the data they don't leave the platform, so they're secure. And so if you find out someone's opted out, you can then remove them and delete them. I'm sure there'll be lots of questions about opt-out, and we are building an FAQs page, and that will continue to grow with questions about that, because we know that a lot of units have found ways that are very clever ways of trying to get around the logistical challenges of the opt-out, trying to manage them in a sensible fashion. Okay, what about dashboards? So the thing about the audit platform, it is not there to inform individual patient care. That is a key thing to understand. The audit is not about tracking care for an individual patient in front of you, but rather it is about gathering information at a service level, at a hospital level, that allows you to monitor your performance. And a key bit of that is about how you put the data in, but then how you get the data back out. How you can see and visualize your data is critical to the value of the audit. And so anything we can do to make your data more visible, more accessible, we want to be doing. So there's quite a lot that is going on. We are building a series of reporting tabs, and so if you click onto that, once you've logged in, you can click on your charts and reporting. These are visible only to people in your trust. So these are not, you can't look at data that you wouldn't otherwise have access to. But you can click on these and you can look through dashboards and here you can see data for Kings, and you can see how actually across the top of the dashboard you select, if your hospital trust has multiple sites, you can select which sites you want to look at, maybe just one of them or all of them. You can look at the date ranges and you can choose your date ranges. You can select just the last few months, and you can select a period across the entire audit program. You can look at benchmarking. So here I've got a benchmarking that is benchmarked against all of the data that we collect in England and Wales, or you could substratify that just to England or Wales. You can select the diagnoses that you're benchmarking, that you're looking at. And so that data is there, and we will continue to adapt, and we will invest more time and effort to make these dashboards useful to people. So you can start to select, I want to look at these patients, I want the frequency of the reporting to give me weekly reports like a run chart, and I want it to just look at those with rheumatoid arthritis. Maybe I want to break it down by gender or by ethnicity. So you're able to, with it for your trust, look at those sort of reports. So you've got a real-time reporting function. It doesn't require any data extract or exports or any sort of statistical analysis. It's there at your hands, and we will continue to try and, depending on feedback, look at evolving this dashboard over the coming years to make it more and more useful to you, so that it enables you to look at service performance and make things better. I will just come back. I know Sarah said we'll come to the question in Q&A. Someone's just said clarify what stages throughout the year data are collected and timeframes to collect data. I will come back to that at the end, but just to say the beauty of using this for real-time improvement is to collect data in real time. So you want to be entering the data as close to the clinical visit and to the diagnosis as possible. That gives you the most power for real-time change, so real-time data entry. I'll come back to the reporting and the time I sat at the end. But now, there are plenty of questions that you can answer with a dashboard, but some questions you can't answer with a dashboard. You need more information, and you need to do things where you want to access. Maybe you need patient level data because you want to link it to clinical information not in the audit platform, so data that you hold locally. Maybe you've got questions where you want to do more complicated analyses. You maybe want to do some actual statistical modeling of something. So you can all access, I say you can't all access, those of you in your sites who've been given the permissions, so you've been given administrative rights within your department, you can go to the clinical control panel. Again, it's one of the toolbar headings, and from that panel you have the option to select your site and the data set. And the data sets you can download include a anonymized clinical data set. So that's things like the baseline and follow-up disease activity scores for those with inflammatory arthritis, the date of diagnosis and the diagnoses for all the other conditions. It also enables you to export the patient-reported outcomes at baseline, and in the current model, patients who have their email entered, it's at 3, 6, 9 and 12 months. And I'll say just a couple of bits about this. So one thing is just to remind you, the patient-reported outcome measures we're collecting are all disease agnostic. The patient information sheet has been updated, and we're actually, the patient panel are continuing to work on the patient information sheet. But the key thing is these, again, this is not about collecting data that you're going to use to change clinical practice for that patient. And we make this clear in the patient information sheet. This is about understanding burden of disease at a national level and trying to understand variation in care and care outcomes. And so the questionnaires are really high-level questionnaires that focus on the disease impacts on musculoskeletal health, so the MSKHQ, which again is a disease-agnostic musculoskeletal impact questionnaire that's developed by the team at Keele and Oxford. There's the work questionnaire, the mental health questionnaire, and then there's a couple of questionnaires which are not sort of specific questionnaires, but a VAS, a visual analog scale, and some process bits about whether you received education linked to your disease. But the questionnaires are all disease agnostic, so that you can download those and you can look at those by disease, and you can look at the trends in patient outcomes. We can provide support in anyone who wants some methodological advice in how to analyze questionnaires. We're more than happy to work with people on that, although all of the information about the questionnaires is in the public domain as well. So how to use your data for QI? QI is one of these things, it is a sort of an evolution from audit, and the leap from doing just audit where you report your data and you say this is where we are to doing QI is actually a fairly intuitive step. A few key things is when you're doing audit, you tend to do episodic measurement of a quality metric, and then you say, how are we doing? You look and then you come up with some ideas to make change, and then you look again. But the evidence is that actually episodic audit has a relatively weak effect in terms of making things change longer term. If you really want to make a change, you've got to measure things continuously and intervene continuously. So intervention needs to be an ongoing. So QI is an iterative process, and it needs to be very much focused on your department. You can't just say, give me the national QI program and I'm going to do it locally. You need to look at your local service, your local patients and your requirements. And crucial to whatever you do is you use data to inform what you do, and the audit platform is your data. So some key tips and approaches. You need to, well, I've chosen 5 here that I think are key things about QI. You need to define a question that's relevant to your unit. So you need to look at issues that matter to your patients, and that may be that the ethnic mix or the language diversity of your patients is a particular issue you feel is relevant. It may be that barriers set out in primary care, or that the access to radiology is particularly relevant. So you've got to look at your unit and say what's relevant, and then look at the audit data collection and see how that can feed into understanding care quality. You've definitely got to engage stakeholders, and by that I don't just mean patients. I mean, it means if you're going to look at change, you've got to get the patients and the audit managers and the nurses and the consultants and the physiotherapists and the departmental sort of infrastructure team, the secretarial staff, your GP colleagues, anyone who follows the referral pathways. You've got to get all of those people in the room or on Teams to say, what are we currently doing? How are we doing it? And what do we want to do differently? There's really good evidence around stakeholder engagement. Getting the right people around the table is really important. Making people feel that it's a shared venture and that it isn't just something that's being imposed on people is crucial. And linked to that, so part of the purpose of getting that stakeholder meeting together is you can do some process mapping. You can start to work out the journey from a patient when they first develop symptoms, to they first see the GP, to the referral pathway, to their letter from the hospital telling about their appointment, to their their first blood test through to the sort of the diagnosis, the treatment. That whole journey you map out, and it's every piece of that pathway you can look at and say what is happening, what are the barriers or facilitators to the best outcome. And you may have, if you go onto the BSR QI work, has done a lot around barrier and facilitator work, and these are often referred to as driver diagrams. There's several of these hosted on the BSR website, and there's lots out there. If you were to ask ChatGPT to write you a driver diagram, it does quite a good one. So there's a big step, which is to look at your pathways, look at your local services, how your service is configured, and then say, where are the levers that I could do something and it would change. And it's quite good fun, this bit. It's the sort of the step where you then can say, let's look at some ideas. And developing change ideas is not necessarily about thinking big. It's about thinking small and being innovative. And anything in the pathway you could potentially change. That could be something really simple about the GP referral instructions. Maybe they're hard to find for the GPs. So maybe just changing the physical location on the hospital website where those instructions are about who to refer to an EIA service or how to refer someone with lupus or vasculitis. Maybe sort of working with the GPs, the referral pathway, making an automated system, a form is key. But actually, maybe it's not about that. Maybe it's about your end. It's about the triage, about how you do triage. Do you have a big pool of people doing triage and everyone does it slightly differently? So how could you redesign triage pathways? I've seen some hospitals do screener questionnaires where when a patient's referred, the patient gets pinged an email straight away, or I think it's a text message, to fill in a questionnaire which screens them for a whole series of questions and helps define prioritization for that patient. And quite a few departments have been looking at those sort of things. I know a lot of dermatology departments have done work around using AI screening tools to improve the selection of patients to the right clinics. Having dedicated clinics definitely helps. And I know smaller departments, this is harder. If you have, particularly if you're in a single-handed department, trying to have one clinic which is just lupus and then one clinic that is just vasculitis, and it's hard to organise. And so this is challenging, but the evidence from the national audit data is fairly convincing that departments that have EIA pathways are more likely to treat people quicker and get people into disease remission. So having an EIA pathway, I think, is an evidence-based thing. And so thinking about dedicated clinics, looking at things like DNA rates, the really good evidence around DNA rate reduction. And I know it's sometimes a sort of a double-edged sword, because we sometimes secretly quite like DNAs because you get a bit of decompression in the clinic. But actually, it sometimes is that if you did, an all new patient clinic and you have 6 patients or 8 patients on that list, and 3 don't turn up, even getting 1 extra in could have a substantial impact on a rolling basis, week by week, on your waiting times. And so, looking at DNA interventions, SMS text reminders, for example, have an enormous impact. They have like a several-fold reduction in the DNA rate. Looking at also at staff that do different roles in the department, I think a lot of departments have looked at flexibility around roles of specialist nurses, junior doctors, pharmacists, physician associates, and being flexible about what the roles people do, and looking at where barriers are, and sort of you get these bottlenecks where only one person does a role, like patient education, because you have one specialist nurse who's expected to do patient education for enormous numbers. So looking at ways you can adapt staff to try and address those bottlenecks. And one other final thing is about diagnostics. And I think some of us, we know, have ultrasounds in clinic by our side and can do real-time diagnostics with the patient in front of you. Others of us are dependent upon diagnostics that are sending someone away to a department, and we then have a delay. And those delays fluctuate. We have a radiographer strike coming up, and so thinking about how you partner with your diagnostics teams is really important. That how do you make the radiographer or radiologist doing the sonography feel part of the MSK team is tough. All of these are ideas, and I don't think it's about reinventing the wheel. It's about thinking about change that is often small-scale innovation that is relevant to your local department, and then crucially using the audit platform as your run chart. It becomes that map of sort of improvement or not over time that you can look on a weekly basis saying, how are we doing? I'm aware that I've almost had my 30 minutes, and so I want to finish just a couple of points. One was I said, what about if you wanted to look at not just your data but national data? And there's various ways you can do that. One way is that all of the published patient level national audit data, you can apply to access that through HQIP. It's quite timely, and there's a sizable fee that HQIP charge for accessing any of their audit platforms. But if you're interested in doing that, we're delighted to help. We know there's been some really great projects that have gone down that route. But the other option is you can also use what is called the extended output process. So just to tell you, so if you are looking at a question, you want to look at it not just at your trust, but across England and Wales. Is your question directly related to the purpose of the audit? And this is an important thing. So this is not a blue sky thinking research question. This is the audit. Obviously, the audit report covers quite a lot, but there's so many questions you could ask that are directly related to our understanding of the audit report, but they haven't actually been answered by the report. If that is what you want to do, talk to us, because we can help you do that analysis, and we can run that through what is called an extended report pathway. We can't share patient level data, but actually we've probably got quite a bit of capacity to do some analyses and give you the aggregate data that will answer the questions, help you with the making sure you've got the right question, that we've got the data to answer it. But that process can be a quicker, and it doesn't have a cost implication, because HQIP are keen for us to do extended reports that are related to the purpose of the audit. If we have people who are enthusiastic and willing to take those ideas forward. And then my final thing was just to come back to best practice, the BPA awards. The best practice awards, the link is in the chat. For those of you who didn't see it, rheumatology.org.uk, best practice awards, open for applications now. And just summarise, I hope we've covered some of the changes that are happening in the audit. Please do give us feedback on the dashboards, because these are going to be an iterative process. We know that as we get feedback, we can make them better. Please do access your data. The more you look at your data, the more difference as a national programme we'll see. And please share your experience around QI, because I've given you, I hope, some food for thought around quality improvement, but the more we get feedback, we can put case studies up on the website and share experiences. I will answer a couple of questions in the chat, but thank you for listening. The QR code for the survey was in the audit, in the webinar invite. It's on the screen in front of you now. Please do give us feedback. And so I'm now going to come to some of the Q&A questions. So the first question was clarify timeframes to collect the data and stages at which the data collected throughout the year. So data collected in real time. The annual cycle is in line with the NHS annual cycle, so April to April. We will give people notice. We start letting them know sort of December, January time about the appending sort of the approaching deadlines for data entry for the year. As that approaches, we will start to then really nudge people to get their data entered. When the deadline comes, we then do a data extract, and that is what we didn't do our outlier reporting on. We identify units that are outliers defined as per the HQIP standard. So someone whose performance is more than 2 standard deviations away from where the average of the national performance is. We then contact those departments, and then there's quite a short timeline for people to review their data locally. All of those timelines are on the audit website to look through in detail. So the outline reporting happens once a year. Throughout the year, the real-time data are available for review for you internally at the trust, and also for when there's things like GIRFT visits or CQC visits. There can be reports done through the year to inform those as well. Any other questions? If anyone's got a question, put it in the chat. I can't see anything else come through. It was wonderful. So outlier status only applies to, so we only report outlier at the moment on QS2. So when the next annual report comes out, that is time from referral to assessment. And for April next year, when we do the cut, the outlier status will be time from referral to treatment for early inflammatory arthritis only. So Chloe's answered that, and Chloe, so the answer to your question is yes, it is only applicable to the inflammatory arthritis cohort. I do hope that you will use the audit for other metrics, and I know that we get the sort of the stick and the carrot. The stick is, you get this metric and it gets sent to the CQC, but actually from a point of view of trying to get the best care for your patients, I hope that you're going to be able to look at all of these and say, well, you know, we will say how many standard deviations are you from how many standard deviations are you from performance metrics for how long people wait for diagnosis of GCA. You can look at that, and that's really important information, but it's not an outlier metric as such. Opt-out is specifically for NHS England. There is a separate process for Wales, but that question which came from Wales, I would suggest you ignore that. So the information, I do apologise. I should have had a separate piece on Wales, and I'm going to suggest we correspond with you afterwards. And I don't know if Sarah, are you in? If you're still there, able to make a note that we will link up with that person, and we should do a separate note for people in Wales. Really good point. Thank you everyone who's come, and I know a few of you have had to rush to clinic, but thank you for joining. You've been a very nice audience, and so
thanks, James. That was a great webinar. Thank you. There was lots of people on the call. And we should just say, if anybody has any questions that they didn't think of during the webinar, they can reach out to us at the audit mailbox, and we'll address those.
Okay, well, in which case, should we call it a day there? Sarah, thanks so much. Thanks everyone for joining. And oh, hi Chan, I saw you joined. Always nice to see some friendly faces.
Thanks, James.
All right, thanks Sarah, thanks Callum, and I will see you at another webinar.